My name is Dr. Leroy Jones, and I'm going to talk about male sexual health. I'm currently in private practice with Urology San Antonio, and also have a clinical appointment at the University of Texas Health Science Center in San Antonio. So today we're going to focus on male sexual dysfunction. Primarily the key topics: erectile dysfunction, orgasm capacity, ejaculation, libido or interest, and then partner health and happiness. Now, this list is not all-inclusive, but I think that these are the important topics that many of the guys will focus on. Let's start out talking about penile anatomy, because I think it's important when we're trying to understand how an erection occurs and some of the things that happen when an erection can occur. So this is a cross-section of the penis, and in the center are very, very small blood vessels, and so these small blood vessels are important. This is the erectile tissue, and when the blood vessels dilate, the penis fills up with blood, it swells, and that provides the rigidity. So anything that's going to interfere with blood flow will cause erectile dysfunction. Well, how common is erectile dysfunction? Well, it's actually very common. This is a slide that shows the prevalence, or how common it is, and if you look across, 40% roughly of guys age 40 will have some degree of erectile dysfunction, and that can include minimal, moderate, or complete, and it goes up about 10% with each decade of life. So it's something that's very common. 50% of 50-year-olds, 60% of 60-year-olds, and so on. So what are some of the reasons? Well, primarily organic, which basically means it's a disease basis. As I said, you need to have good blood vessels, so it can be vasculogenic, neurologic causes, medical causes, hormones can be imbalanced, as well as medicines can affect erectile function. There's also can be a psychological component, and certainly that will contribute to the degree of erectile dysfunction. In many patients, it will be mixed. But really, when you look at overall reasons for problems with erectile dysfunction, probably about 70% of it is going to be organic or related to some type of disease state. And anything that injures the blood vessels, again, we kind of go back to that anatomy slide. The lining of the blood vessels is called the endothelium. So anything that injures the endothelium, oxidative stress, so disease states such as high blood pressure, diabetes, obesity, high cholesterol, smoking, it will injure the blood vessels, and then the blood vessels don't function normally. And again, this is just to kind of give you a basis. The penile artery that we talked about is 1 to 2 millimeters in size. And if you compare that to some of the other blood vessels, the left anterior descending, or the coronary artery, 3 to 4, carotid, and the femoral. So it's typical for patients to present with erectile problems prior to heart disease or other blood vessel issues, because the blood vessels are so small, they're easily affected. So what's going on with diabetes and so forth? Well, this is a slide that shows what's happening with diabetes from 1958 to 2009. And you can see the slope, the rise trend in diabetics in the United States is something that's very, very common, unfortunately. Over 25 or almost 25% of patients in the U.S. have been diagnosed with diabetes, so it's a very, very high number. Another slide that looks at obesity trends, and as I said, obesity is a risk factor for both heart disease and erectile dysfunction. And you can see on here from 1990 to 2000 to 2010, the definition of being obese is a 5'4" person that's 30 pounds overweight. And you can see that in 2010, a fair percentage of the United States would be defined as being obese. And this is the trend that's evolved over the past several years and is likely to continue to get worse. So these are some of the reasons that erectile dysfunction will continue to be around, and unfortunately will likely increase over time. So when we look at treatment, obviously we want to address diabetes, high blood pressure, high cholesterol, and so forth. But once that's done and optimized, then we look at treatment of erectile dysfunction. Typically, we start out with oral medicines, the PDE5s or the phosphodiesterase type 5 inhibitors, which we'll review. Psychosexual therapy, if it's indicated, and then what's called a vacuum device. Some of the second-line therapies: injection therapy, intraurethral suppository, then finally surgery. So we're going to go ahead and review the different treatment options. When you look at the PDE5 agents that are out there, sildenafil, vardenafil, tadalafil are the three big players, and so that's Viagra, Levitra, and Cialis respectively, and this is just sort of the chemical composition that you can see. So they're all in the same family and they all work in the same way. But the reality of it is that the overall efficacy or effectiveness is only about 65, maybe 70%. And as the patient has more disease problems, so for example in a diabetic, the chances of the medicines working are about 50%. And if you add high blood pressure, high cholesterol, the chances of the medicines working will decrease even further. The vacuum device, essentially what it is a vacuum that goes over the penis. Suction is applied, and there's either a handheld manual device, a pump, or a battery-powered device, and that creates a vacuum. And the vacuum draws the blood into the penis. And when the penis is erect, there's a little band, a constricted band, you can see in the FAR diagram on the right, that keeps the blood trapped in there. And so for some people, this is an option for treatment. There's also injection therapy, and what that is where the patient is taught to inject themselves. They typically will use an insulin-type needle and syringe, so it's a very small needle. They inject the penis with this medicine. Again, it affects the blood vessels and allows the blood vessels to dilate and create an erection. And the chances of that working compared to the pills is maybe about 80%. And then lastly, there's an intraurethral suppository, and that's a little pellet about the size of a grain of rice, and it's just like the medicine that's injected, but the medicine is put into the urethra, the urine channel. It's absorbed transurethral into the erectile tissue, leading to the erection. The efficacy is not as good with this type of therapy, only about 40%. Now, there have been lots of studies that have looked at patient happiness, sort of outcome studies, and this information is all published in the urologic literature. The vacuum erection device, 75% of patients aren't satisfied. Muse, the pellet, has a small refill rate. And then injection therapy, even if patients are excited about being on injection therapy, it has a high dropout rate. And so what's next when patients fail conservative treatment options? Well, what's next is something that's actually been out for quite some time, and that's the inflatable penile prosthesis. This was designed and invented by Brantley Scott. He was actually a professor of mine when I was at Baylor in Houston. And this is one of the first devices, and certainly very complex. Inside the two chambers that normally fill up with blood are the cylinders, as you can see down here. And then back then there was a pump on each side and then a little reservoir that holds the fluid. Well, obviously something that's been around for 40 plus years has changed, and so it's much more streamlined. Now there's a single pump. These devices have excellent mechanical survival, and so they'll last for 15 to 20 years in 90% of patients. We've done outcome studies. It has a high degree of patient satisfaction, partner satisfaction, and probably one of the biggest things that happened in 2001 was antibiotic coating of the devices, and so the infection rate in the non-diabetic is less than 1%. And these are 30 or 40-minute outpatient operations, and so everything has really evolved. This is just a slide that just kind of gives you an idea of the device. There's a pump that's in the scrotum. Inside the erection chamber is the cylinder, so there's one on either side. And then there's a little reservoir, and the reservoir holds fluid. The fluid is saline, which is sterile water. And this is just a close-up of this particular design. This is the inflation bulb, this is the deflation button, and then everything is connected by tubing. And as I said, typically a small incision on the front of the scrotum, maybe about 1.5 inches or so, and all the components can be placed in here. And again, this is a 30-40 minute outpatient operation, so patients do very well with this. This is just another slide depicting another company. You can see what the pump looks like, and then the deflation. This is called the one-touch release. And then in the erection chamber are the cylinders, and then the little reservoir. So these are called three-piece devices, even though they're two-piece. So let's take a look at a animated movie of how a patient inflates this. So you can see here basically what the patient, they feel through the skin. It's important to note that nothing is outside of the body, and the patient will pump the pump through the scrotum, and then the fluid transfers from the reservoir into the erection chamber, and then that provides with the rigidity. And then when the patient is done, they squeeze a little button, and then the fluid then returns to the reservoir, and the patient's penis becomes flaccid again, and so that's how that works. So this is what the pump looks like, and so my fingers are on here just to give you a point of reference. So again, in this particular model, this is where the patient will squeeze to inflate, and then this is the deflation button to make the device flaccid, or the penis soft, if you will. So, and then this is just another slide, just looking. The orange color is the antibiotic coating. The other device that we use, we dip in antibiotics, and so we have great choices to treat patients to keep the infection rate low, and patients do very well. This is a slide that was done by one of my colleagues, Dr. Dubois, up in Michigan, and basically what he did was query patients on happiness, satisfaction, and they actually looked at compared to pills, and then injections, and then penile implants, and you can see even though the penile implant was the most invasive of all the different treatment options, that had the highest satisfaction as compared to pills, oral medicine, or injection therapy. And so, again, penile implants have been around for over 40 years, and patients do very well with them. Talk about testosterone. A few words about that. We certainly hear lots about it, and some of the symptoms associated with male hypogonadism or low testosterone, it can affect the patient's mood. Physically, there can be a loss of energy and fatigue. Testosterone is also important for bone strength, and so low testosterone can lead to osteoporosis. And then it can also affect desire, interest in sex, and as well as in some patients it can cause erectile dysfunction. We don't generally screen for all patients for low testosterone, but some of the populations that we'll screen, somebody has diabetes, chronic pain control use, kidney disease, on dialysis or end-stage renal disease, lung disease, HIV associated weight loss, osteoporosis. And so these are some of the reasons where we would screen for low testosterone in patients. And we have lots of different treatment options for patients, and I think it's important to be aware of what's out there. There's topical therapy or gels, injection therapy, pellets that go inside the mouth, as well as subcutaneous pellets which go underneath the skin. So we certainly have evolved from injection therapy, and there's typically an answer for all patients. So thank you for listening to our lecture today on male sexual health, and hopefully we help clarify some of the questions that you may have.